Assalamualaikum warahmatullahi wabarakatuh. Good afternoon or whenever you watch this podcast. It's nice to see you again to continue our next session of the podcast series of drug delivery system. And for today, it's still with me as the moderator. I'm Adiat Mika from the Lab of Physical Pharmacy and Biopharmaceutics, Department of Pharmaceutics, Faculty of Pharmacy, Universitas Gadjah Mada. And in this section, we will discuss about the modified release drug delivery system. And I'm also very exciting that I would like to introduce you to our source person of this session. She is Dr. Malindian Laxitorini. She is just back from her PhD study in Canada. So yeah, she's here with me, and today she'll be my source to discuss about this topic of the modified release drug delivery system. But maybe before, would you like to introduce yourself a bit? What you're doing during your PhD study there?
Hey, my name is Malindian Laxitorini. People call me Marlene. I'm in the same lab with Pak Adiat Mika in a lab of physical pharmacy and biopharmaceutics. I joined this campus in 2009 and just come back from PhD program. And I'm doing the blood-brain barrier, basically understanding the mechanism of signaling pathway that regulate the blood-brain barrier function. That's it. That's from me. Yeah, nice. I just newbie in this faculty.
No, not really. But okay, it's nice. I mean, later we'll have another session with her about the delivery to the brain. But just stay tuned for that section. And then, but for this session, we will discuss about this modified release delivery system. Sure. I mean, it's really nice. Well, we can say that the conventional release. Basically, we just give the medication, the drug to the patient, and then we just let it go as the physical properties of the drug and things like that. But this modified release is basically something else. But could you please explain a bit about what is the difference between the modified release and the conventional release?
Right. Before, thank you, Pak Adiat and KPF team for having me. Before we jump to the modified release drug delivery system, I'd like to just a little bit share about the things that maybe you're maybe interested. It was my experience when I was in undergraduate school. It was in my fourth year. At that time, I was excited about, okay, now I'm fourth year, I write something. What is basically a pharmaceutical science means? I wrote in my, maybe in Indonesia it called in the course or in kos-kosan. I wrote in the board, I wrote, as a pharmacist, we have to deliver the right drug at the right concentration, at the right time, and at the right place, and also at the right sufficient amount of time. That was, I think, okay, as a pharmacist, that I should do. Deliver the right drugs means, hey, we have to deliver the right drugs. Maybe if there is any metabolism, we have to choose which one, that active pharmaceutical ingredients that really reach the target. Maybe not the metabolite. We have to think about that one. And the right time, we have to think about, for examples, hey, we have to give it the right time as a pharmacist. What time, if, for example, every 8 hours. But for us as a pharmaceutical scientist, we have to know the right time means what time this will give an action. For example, if you have the analgesia or headache, the drug for the headache, what time it's going to be work, what time I'm going to be forget my headache, for example, like that. At the right place, hey, we have to put this drug at the right place, means what's the target of action? Is it in the eyes? Is it in the colon? Is it in the lung or in the skin? We have to know. We have to deliver really the active ingredients to the place that the action is taken place. And then sufficient amount of time. We're as a pharmacist, as the pharmaceutical science, we are not just sending the right drug. We're already in the right place. We already, yes, it's given action faster or right away, but we have to make sure that it's sufficient amount of time. For example, how many duration, for example, oh, your headache is, yeah, it's relief after 5 minutes, the headache is relief, but the duration of action is really short. For example, after 1 hour, you have another headache. That also not the aim of the pharmaceutical science. Yeah. So that was the things that I think later on in my study, in my master program, I figured out, hey, what I wrote in the course science is basically the philosophy of the drug delivery system. So yeah, so that's maybe not only applied as a pharmacist. Whenever you work, you think about that way: right drug, right concentration, right place, right time, right sufficient amount of time. But as a pharmaceutical science, as a drug delivery system scientist, that's our aim. So that's just introduction about the drug delivery system.
So yeah, so basically we need to put the drug in everything right?
Yeah.
And then in order to do that, we cannot just give the drug as it is, okay?
Yes.
So then we need to do this kind of modification. But if we can discuss it a little bit more specific, what kind of modification we can do to the delivery?
In terms of the drug delivery or modified drug delivery system, we modified the release. So, for example, there are 3 things that we modified when it released. When it released. The second one is where it released. But another thing is also still where, but it's more specific. It's still where, but more specific in the organ or in a cell or in the receptors. It's targeted release. And also in the modified drug delivery system, we try not to make them release right away, not immediate release, but we control when. We control what's rate and where. Yeah, that's the main point. That's make the difference between conventional drug delivery system and also the modified drug delivery system.
Okay, then let's talk about it in a more specific way, one by one. Okay. Okay. For example, as you mentioned before, that there is a problem and we don't want to get another headache in just 1 hour. Yeah. So then we have to take the drug like in every 1 hour.
Yes.
But then in that case, if our drug needs to be extended for the release time, so then could you please elaborate more specifically about this strategy to extend the therapeutic action of the drug in our body?
So in terms of designing the dosage form, then make them to be able to release not right away, what we can do is, for example, we mix the granule, you know, the granules, and then this granule have different thickness of the coating. So the coating, one of them, maybe the coating is just very thin, and then a little bit what do you call thicker, yeah. And so, then this thickness when it's reach the gastrointestinal fluid, it will be releasing the drug, but it's really come back to the barrier, which is the thickness of the coating. So one release, and then they get absorbed. They show the effect, and then it gets eliminated, right? And after that, we supply them with another dump of the second dose using, like, for example, the more thicker coating and so forth. So there is more than one drug liberation or drug liberation from the system. That's one that we can do. The other one is also not the granules, but also we can use as a multiple layer tablet. In the multiple layer tablet, it's the same basically, but we have like maybe, for example, one tablet have the matrix system that will give them immediate release. The second one, we give a different matrix system, for example. Okay. Yeah, for example, it's for example designed to be activated or deliberate in certain pH, and the other one, for example, different compaction. It's really broad. We can explore it. You are also welcome to see or explore in literature, also in Google, of course. Yeah.
Well, it sounds really nice to me, but I think if we talk about this kind of technology, then I think it's not just a normal technology that we can do in a normal way. Of course, it will take more sophisticated instrumentations and technology, and of course, you don't want to just sell painkillers, right? But do you have any other example, maybe what kind of therapy or medication that can be applied for this kind of technology, for example, other than the just for headache, for example.
So I guess the biggest need for the modified drug delivery system is basically still the same, not headache, but for analgesia, the painkiller, but it's for post-operative, post-surgery. They really need analgesia for longer time, strong, but there is no fluctuation in the dose, because in the pain medication or pain pharmacotherapy, we have to really make them to be able to always above the minimal effect concentration. That's really important for the pain medication. Because if they have the chronic pain, the concentration up and down, once they experience the pain, and then they will remember a trauma, and then they're not maybe they don't have pain, but because they already experienced the pain, they think that they have pain. That's the case that happened with the post-operative. So we have to really make sure that it is always above the minimum effect concentration. That we can do with the control release or sustained release, something like that. The other analgesia for the pain, it's also for the cancer patient. So in terms of the cancer, we have somebody who always have the chronic pain, and when it's the stage of the cancer is increased, for example, stage 4, the pain is become exaggerated, higher. We have to always increase the potency of the drugs. So to prevent increase the potency of the drugs, for example, change to the morphine, change to haloperidol or something higher than that, we have to really able to maintain that kind of level, minimum concentration level. Because in a cancer, once we have the pain, when it's the stage is very late, it's really what it called, I cannot imagine, because when I was in my graduate school, I have the close friend that have the cancer, and finally they passed away. I know that at the end, it's really painful. Then what they can do is only give them morphine to be able for them to be not feeling the pain. So we have to really help the patient with the cancer using the modified drug delivery system like this, and that's one of the big market for that one. So they have durogesic and a lot of stuff. That's analgesia, right? The second one is the hormone. So in a hormone, we have the estradiol hormone replacement therapy. That's for example, in abroad you have, people have a transgender, they have to take hormone, for example, from the men to become a woman. They have to consume particular hormone drugs, and that's a chronic, and not 1 or 2, but how many months they will do it. That's hormone. And then the third one, of course, it's definitely it's antihypertension. In hypertension, we also need to maintain the minimum effect concentration. Especially, we have to really control the blood pressure. especially for those who already have like severe hypertension. They have to be really controlled. If, for example, the blood pressure 180, 170, anytime they have what it call incidents or what it call something that trigger, it will be fatal. So we have to really control, reduce it all the time. Because in hypertension, the drug, if they are not in the hypertension, if the drug is not there, the blood pressure going up rapidly. So we have to really control all the time. That's the third, and the last one is, I think, the chronic one, which is also important, but the market, I'm not sure, is high, especially in Indonesia. It's for the psychotropic drug, for example, the seizure, antipsychotics for the bipolar disorder, something like that. For us, maybe it's not important because it's not rare. It's rare, but out there in other country, in the U.S., Europe, mental disorder is really pretty common. So they have to be controlled, and it's chronic therapy. So that's also another market for the
I think
modified.
now in our dynamics lifestyle, I think it becomes more and more.
Maybe it's emerging or in the pipeline in Indonesia that we have to be like, maybe it's,
or maybe it's just about the awareness. I mean, it happens to a lot of people, but they just don't aware.
What about in Europe? How is the mental disorder?
I think it's more or less the same because we have especially during the winter time, then the number of the suicide is higher.
You're right.
Because they have this kind of white feeling or something like that. Monday and things like that. So then I think it's the same problem. It does not trigger by the winter itself, but the winter make it severe.
That's what I feel
and
too.
I think it's also related to the vitamin D or something.
With the sun. With the sun. That's what I feel too. Depressed with the PhD and the sun.
I don't know.
And for me, it's 6 months. 6 month winter. It's done.
Something like that. So then, it's really frustrating sometimes. But since you also mentioned cancer, I think the urgence to use the protein pharmaceutic is then now proposed. The approach with the protein, and you mentioned that it's possible to do hormone with this kind of extended release. So I guess for the protein as well, right? To do the
protein. It's control. Definitely, modified release drug delivery system is really important for the protein stuff. But it's already discussed in another. Right, in another series. Well, you're the connection with the previous session. You're the master on it.
And I think now, other than extending the time, we also want to have a kind of delivery that can be delayed. But how we can do this delay for this?
So in terms of the delayed release delivery system, they don't want to have the drug disintegration or drug liberation in the stomach. We know in the stomach we have the most available fluid for the disintegration of the tablet or the granule. But sometimes some of the drugs have sensitive to the pH in the stomach.
So that's why we don't want the drug to be released at the time, and then we want it
we want it later. To protect them from the pH. So based on the pH, also the difference of the pH between the stomach and the intestine, we can design the drug which is incorporated in the matrix or drug that is protected in the coating that can only activate it in the pH of the intestine. For example, as far as I remember, it's phthalate, cellulose acetate phthalate, but you can always explore. As far as I remember, the one that have phthalate on it, they can be activated at the pH 7 or so. And then the other one, I think, is Celac. Could be Celac. Please always explore yourself because we have like limitation in the what it called, memories. Getting older, aging or stuff. Yeah.
Well, nowadays we can just pick our cell phone or just do the Google. But basically, what we want you to have is the understanding of how it works, right? And then, as you mentioned before, we can delay this kind of system, for example, using the pH mechanism, right? We can avoid the disintegration in the low pH, in the acidic situation, and then for later to be.
Yeah, that's based on the ionization. If you come back to physical pharmacy, drugs have different ionization stage in a different pH. If they have different pKa, that's where it works. So it's based on the ionization of these kind of polymers. So don't worry, physical pharmacy is always used whenever you are. You'll always remember, and it will be used. So
well, I think this message is important because students, I know they don't really like formulas and
Henderson Hasselblad, you will always use it whenever you are.
So then use the example of how we can apply the equation. So you need to understand. You don't have to memorize everything. But
the concept
you need to understand
the
concept. Okay, but this delayed approach, I think it's not like 100% similar, but I think I got the feeling that it's kind of targeted, right? Targeted delivery. Not the target as the organ, but the target and where we want it to be delivered, right? For example, like we have, for example, if we want this drug to be released in the colon, for example, then we need to prevent this drug to be disintegrated along the way until it then something like that.
By the way, what do you think about how to make them not disintegrate or dissolve in the intestine and they will do it in colon?
I think for most of the cases, it's quite difficult to be sure that 100% of the drug is not disintegrated, especially along the intestine, because it's really a massive length of this tract. But I think we can try to, for example, create a matrix that it will need to have a very excessive amount of water, and then we know that this water is regulated in the colon. So because for nutrition, for example, and compounds like that, it's regulated along the gastric and the intestine. For the colon, actually, it's not for the absorption, right? It's basically only the regulation of the water. And then I think there we can exploit this difference. And secondly, I think we can exploit the benefit of having a lot of bacteria inside the colon.
Yeah, you're right. Because the intestine they don't have, right?
Okay,
the
so
different,
then they will do this enzymatic reaction and things like that in the colon. And
okay, I guess. Okay, remember.
Well, that's what comes in my mind.
Me too. I think I think the difference between the ileum and also the duodenum compared to the colon is the presence of the bacteria. So you get to identify what the bacteria is, and then what are things that can metabolize by the bacteria. What can cut? What they can cut them. What they can cut.
With things like that. So that's what the concept. But I think if you maybe find other approach, then you will always find something new. You can also use encapsulations that can be triggered with a very advanced technology. Using. So but I think for the basic, that's more or less basically, what I always tell to students is that we have to really know the environment of the target that we want to. And that's really important. I mean, we can always exploit things if we know what is happening.
It's true. I also would like to underline or emphasize to the student, hey guys, you know what? The drug delivery system is the ultimate or the comprehensive comprehensive subject ever in the pharmaceutical science. For me, because I'm the teacher of the DDS, so I think that's the ultimate. Why it's ultimate? Because we involve everything. We involve physical pharmacy, pharmaceutical technology. It involves pharmacology, anatomy, physiology, pathophysiology, drug synthesis, everything. So really in the drug delivery system, you really kind of gather and try to design and decide what can we do using all the knowledge that you already gather in 3 or 4 years. So that's why I'm proud. I think Pak Adiat also very proud to teach the drug delivery system, because it really help you, or it really we'll work together to help you take any puzzle that you already gather to make you be able to decide or design. I think that's the coolest thing of the drug delivery system.
Well, last week also, last session also, Pak Roni said that he also have a campaign about this delivery system, because with this delivery system we don't have to always make a new chemical entity of the drug.
It's true.
And it will take like at least 5 years until 10 years.
Yes.
And with the delivery system, we can just have the drug as it is,
yes.
and then from there we can just work on, and will take maybe 1 or 2 years. That's possible.
It's really important to know, and also, for example, you're in a community pharmacy in a hospital, get close to them. For example, you're in industry, get close to them, know what's the need of the patient, know what's the need of the doctor, to get answer what is really needed in terms of the drug delivery system, what kind of the patient need. Sometimes we don't know, sometimes we just read the book, but if you talk to the doctor, if you talk to the community pharmacies, you talk to the hospital pharmacists, they know, hey, my patient actually need this drug. Doesn't really work, because we also, for example, the doctor give the prescription, many drug, this together, can you industry make this become one dosage form or something? Be always connected. That's another key point, I think.
Okay, nice. Since we talk about the delayed release that feels like it's targeted, now we will talk about the 100% of targeting. Okay, so one of the kind of modified release delivery system is the targeted delivery system. So could you please give a little bit of the description about this targeted release? Yeah,
in terms of the targeted release, you have to really know what's, for example, you have to really know, for example, you have the chemical drugs, how it transfer across the cells. Is it passive diffusion? Is it through the vesicular transport? Is it through the paracellular? Or is it through the transporter, influx or efflux transport? That's really, you have to really understand how it cross the cell. Not only cross, for example, the epithelial of the intestine, but how it cross the
cellular membranes,
the cell membrane of the target cells. For example, you target hepatocyte, your expertise. You have to know what is the hepatocyte really, and what's the circulation is, make them in that kind of organ is different from other circulation, what kind of the transporter in that what it call the blood vessel there. So that's the things you have to we have to understand the mechanism of the drugs transport across the cells. The second one is what is unique about that cell that you want to target, what the cell is expressed, how it's different from other cells. For example, if in my area, when my area is brain endothelial cells, they have specific that are not expressed by other cells in the body. For example, they have transferrin receptors. That's also something that we can do. The name is Trojan horse strategy. So we package the drugs and connect it to the transferrin, so that only the one that connected to the transferrin can cross this kind of brain endothelial cells. What about another endothelial cells in the peripheral circulation? No, because there is no transferrin transporter. So they just, when they go and they don't see the transferrin, they just go right away. But you have to remember that the drug is not static. They always circulate it around the body. Whenever they found the receptors, for example, transferrin receptors, they get transported. That's another thing. You have to really know the cell, the pathophysiology of the disease, how, for example, how it's different. For example, you target a cancer cell, how the cancer cell is different from the normal cells. What receptor is different? That's really, you have to, I guess, that's what I say the coolest part of the drug delivery. You have to really know what the physiology, what is the pathophysiology, anatomy and stuff. We have to really know what is the difference of one cell to another cell that we target, so that you can decide which one that make them specific, distributed or deposit to this particular cell.
And I think, as also you mentioned before, in order to really know, because this kind of drug is basically is also capital, then we need to do a market analysis, and then as you mentioned before, we need to keep in touch with the doctors, because only they really know about what kind of
what's different.
We can design, but we don't really know what needs to be designed. I mean,
what's the advancement? What is new?
That's right. Okay.
we read the textbook, but the textbook is 10 years, 15 years before. The new is
And because our design is basically to solve patients' problem, and we don't really meet patients day by day, and we need to ask the ones. So then keep in touch with the
maybe
doctors.
You can true. Maybe you can add about the targeted drug delivery system. I know you also have the long history of expertise in this area.
Really. I'm still starting, but it's true that I'm interested in that sector. Yes. But
Let us know. I mean, I'm interested to. It's really what it called minimum understanding about the target. That's what I understand.
We always feel minimum, because when we already understand something and then we see again from the PubMed and we see something else, something new. Well, it's really exciting actually. Well, we have already discussed about the different approach of this modified, but actually, in order to know if our approach is then successful or not, if it's good or not, if the quality is right, like what we want or not, we need to do evaluation. And then in order to do the evaluation, we need to know what kind of parameters that we can use to assess this success or not.
Oh, wow. Evaluation, I guess.
For example, like for the extended release, what can we use as parameters?
I guess we have to have the bioavailability study and PK PK study. I also would like to add about the modified drug delivery system. The things that we really have to be careful is the out of spec. Out of spec. If you know, in industry, one time you produce 1 million of tablet. How do you know that all of them is correct? Because in the modified release drug delivery system, for example, you combine 3 or 4 doses together, right? You don't want, for example, all of them get released immediately in the same time. That's gonna be deadly, I think. I mean, high above the minimum toxic concentration. So we have to be really careful to make them make sure that all of them is meet the specification. We really don't want if any error that make them immediate release, because we combine together 4 or 3 doses together. So imagine if you, for example, supposed to have 500 milligram and that's a bad example. I correct. For example, you have 2 grams. Suddenly you have 8 grams, and all is absorbed together. That's not things that we have. That's not nice thing. So we have to do dissolution, of course. We have to do,
so with the dissolution,
and then we have to do the PK study profile to make them make sure are they really extended release?
So then it's something about the half-life?
Yeah, half-life, and then the onset and duration,
yes,
time by time. But if it's in industry, we cannot do. I don't think that we can do every animal study, every batch we produce, right? So we control them using the dissolution profile. But before we have to do the PK study and do IV-IPC.
Oh, yeah. IV-IPC, okay.
Yeah, I guess so. And then I also remember if we want to design drug delivery system which is modified release, extended release, sustained release, controlled release, we only choose the one that have the small dose or the potent one. What I mean is, for example, you have 500, you will 500 like paracetamol. You want to combine them to be like prolonged release, to be able to only take one paracetamol a day, and then everything is covered. But 500 multiplied by 4, for example, it's 2,000. And how big is the tablet? So got to be like think of also that way. For if you design, what do you think the tablet will? How big is your tablet? Something like that. That also need to be considered. And then the other things is the other thing that we have to remember, for example, we cannot take the drugs, for example, that have half-life elimination less than 2 hours. I know the less than 2 hours, but it really depends. For example, if it's less than 2 hours, we combine them. But it will need lots of drugs to be able to cover, for example, 24 hours. But that's exception if you have small dose. If the elimination half-life is 2 hours, if you have small dose, it's okay. Yeah, because you have small dose. If it's multiplied by 4 or 5 or 6, you still have small tablets. So yeah. It's cool because you have to really make a decision. That's the thing that. And
I think if I imagine, you also need a different level of compliance. You know, because people sometimes they just take twice as much as what the pharmacist told them to do, because they feel that, okay, I still have this pain after 5 minutes, and I'll take another one. And it becomes really dangerous if it happens to this kind of modified release.
Yeah, you're right. It's through patient compliance.
So I mean, it's also not only the design, but also how we deliver to the patients.
Yeah, you're right. That's why the right time, the right dose is not only for pharmaceutical scientists, but also for community, and every pharmacist should think that way.
We need to work comprehensively. Like, as you mentioned, as the science itself, we cannot work together in our lab, for example. We need to work together with the lab of pharmacology. So then we can make a nice delivery.
Yeah. But I also would like to underline that, you know, in a drug delivery system, the tablets still look like a tablet. So it's really important for the pharmaceutical scientists, for pharmaceutical that work in the community pharmacies to really stress, to really explain, to really give the drug information to the patient or the family of the patient, to make sure that, hey, this is look like a drugs. It's the same like a tablet, but don't take more than as indicated. That's really important message for you who are really want to go to the clinic, community pharmacies. Always remember, if there is any drug with the code XR, XR means extended release, and then SR, sustained release.
So there are codes to this.
There is a code. Nice. So but you know, Indonesian patients sometimes they just don't read. So it's really important for you as a pharmacist to really explain to them, hey, Ibu, this is have XR. No, in Java. Ibu menika wonten kode XR, jadi ini minumnya. Make them really understand that it's different from the common tablet that they consume.
Okay, and but if we talk about how we deliver to patients, that also usually the things that we give to patient needs to be available in oral delivery, right? If it's injection, then usually you give it in clinics or hospital. But how is it different in the design if we have to kind of create a modified drug delivery system for the parenteral and parenteral? Do you think the one something is more difficult than the other, or basically they are the same difficult?
Do you mean the modified release for the parenteral?
Yeah, oral, yeah, parenteral
Oral and oral.
parenteral. Are there any difference, for example, in the at least in the difficulty in general? What do you think?
I guess if we talk about the modified release in the parenteral, we have restriction in terms of the elimination.
Okay.
Right. If they for example circulated, they enter the kidney, they get filtrated. That's it.
Okay.
Right. But in the gastrointestinal, we have something that we can make them retain. For example, the mucoadhesive stuff that stick to the wall of the intestine. They make them together. They make them stick there, releasing the drug over the time longer. So they have always something to be absorbed. There is always supply for the circulation. We also have swelling, the tablet that can swelling in the gastric juice, so it float, so it will never, like for example, it will not enter or the pylorus, the what do you call? I think it's pylorus.
Yeah, the connection. Yes, the connection between the stomach and the intestine.
That one. That's the positive point about the gastrointestinal or oral drug delivery system. We have something that we can modify in terms of make them retain or make them sustain, stay there and keep supplying. I guess in terms of parenterals, the circulation is really like the circulation, the elimination half-life is really what it called, it's already there. To make them not following that things, I'm not sure. Maybe you can explain that. Like, I'm not quite sure about how to make them, especially if they are connected to the protein. Maybe they can retain in the filtration. That's maybe a way, but
I think it's the same as you mentioned, that basically if we want to have different kind of modification in the release, we just talk about metrics. You know, if we want it to swell or not, if we want to, you also mentioned different thickness of the granules, and usually it's kind of different term of metrics, right? It's the thickness of the things that basically as a vehicle of the drug, of the construct. And I think that also apply for both in the gastrointestinal tract and also for the parenteral.
Do you mean like, for example, the matrix will be the oil or something? Is that what you mean?
That's also possible. I mean, we can also use polymers. We use a lot of polymers if we want
injectable? So
yeah,
it's injectable.
That's also possible. That's why the nanotechnology is special, because we cannot inject a particle larger than the nano size, because it will stuck in your blood circulation. Yeah, but I think in a controlled size, we can still have not only solution but also dispersion.
Oh, really?
That's possible.
Sorry,
I guess.
I was like missing that part. Okay, I thought that it should be like.
I mean, do you know
so
that
injectable.
We can kind of do the infusion of milk into our blood? Well, it's not real milk, but sometimes you can see the white thing, and because we need to do the emulsification, and then with the emulsion, it's droplets there. So it's still possible. In that kind of size.
Okay.
Not too big, but I mean, at least with that size, we have kind of freedom. Well, there's a degree of this freedom, but we have freedom to modify this, and we can basically we can use nanoliposome, and it can be also administered.
Sorry, you're right.
For some research, we use the PEG to make it stable, and then I think that approach we can just extend, at least as you mentioned, it works the same with the matrix in the customer's
and that thing is retained in the filtration?
Well, at least longer.
Longer, yeah.
I mean, it cannot avoid all the time, but it will become, in the blood for the longer time period. Usually, it needs to be metabolized first in the liver, right, to make it more polar, and then it can come to the kidney. But yeah, we can always play with that.
And to the size.
Yeah, I think.
Yeah, you're right.
It's all about matrix.
Yeah, the matrix. Yeah, I forgot that the people injected liposome. The people inject the nanoparticle. I forgot. yeah. So that's also another approach.
Basically, not solution anymore, right? They're not in a molecular size. They're bigger than molecules, but it's still okay if it's not too big.
Yeah. Thank you for reminding me that things I completely forgot.
I mean, that's why we discussed. I also have a lot of insight from you, and it's really nice also for us to do this.
We have to do it often.
Oh yes, that's why. I mean, that's why we do it podcast. I mean, normally, students, you got just one session from me or one session.
Yeah, this one I got something from Padi, which is
something different. Okay, so then you can also get more from us. Okay, but again, we then talk about metrics. And do you have any insight about what kind of metrics, for example, we can use in general? Of course, with the properties that, it needs to be biodegradable. But what kind of the example of the metrics that we can use for this?
As far as I remember, if they do nanoparticle, I'm not really nano person, but my boss doing nano. That's what I remember about when they discuss. They talk about PLGA.
Okay, but it doesn't have to be nano if we just administer it through oral, right?
Yeah.
For example, for per oral.
Oh, for per oral.
Yes.
Yeah, for per oral, we can use the HPMC. That's where you can control the swelling.
Okay, HPMC.
Yeah, HPMC.
So basically, it will absorb water
and swelling,
and then it will swell. Okay.
The other
this is for the floating purpose?
Yeah, that's for the floating purpose. And then in terms of the erosion, like the tablet that can erode slowly, I couldn't remember, but it's your job. I think. Find the polymer that can erode slowly.
That's right.
Yeah, but that's available.
Yeah.
We use when we are student, we used to always open the handbook of drug excipient. Did you remember?
We can find them there also. Okay.
Yeah. Okay. We can find them there. But if you want to be fast, just Google it. If you find the review paper, just read it.
Google is okay, just for the start.
For the start.
Don't use it as your main source.
Yes.
But for the starting point, it's always nice to make it quick.
To know what's the keyword, the words that you want to find further, use Google.
Okay, but if we talk about the matrix like that, we only consider physical properties, right? It's like, swelling and things like that. But is there any involvement of the chemical reaction, for example, in this modified drug delivery system?
Yeah.
Can we use that?
Yeah, we use that one. They use I think they use resin.
Okay. Resin.
Yeah, the resin that can like ionize that I mentioned before.
Okay, so first the example maybe the ionization.
Yeah, and then they also use the drug stat conjugation, right? They do drug conjugation. With kind of the polymer or kind of the matrix, they do drug conjugation. So it's chemical reaction, and this chemical reaction will be cleave or will have a hydrolysis in particular pH. That's something that we can do.
And you mentioned before also something is pH sensitive?
Yeah, the pH sensitive
reaction,
Yes.
The reaction
Thermosensitive one.
Thermosensitive also possible, okay.
For example, thermosensitive means, the room temperature is 20, 25, but in our body is 37.
Yes.
So it can be activated through the body fluid or our body temperature.
Okay, nice. So I think it's already a very comprehensive discussion about this. I mean, just for the introduction, okay? So it's not all about that we know nowadays in the world about modular release. It's just for you to start about your next exploration about this. But let's just make a kind of summary about this. So first, basically the modified release, we use this to make sure that everything is in the right point, okay? Right period of time in the delivery, right place. And what is it again?
Right drugs.
Right drugs.
Not the
okay.
metabolite, not something that's not active.
Yes.
Yeah.
Okay.
We have to protect them, right? For example, yeah.
So that's one point. And the second one is that we can do some approach. First is that the extended release of the drug, and then secondly it is the delayed release of the drug, and then the third is the targeted release of the drug. Okay, and then we can exploit things like in our body, to make it swelling with the matrix, right, and pH sensitive, thermosensitive. Okay, and then enzymatic reactions, as you mentioned before.
Using we check what is the enzyme in this particular segment of the intestine. That's also possible to check.
Okay, and then in order to know the quality of our design, we need to use some parameters. And you mentioned about the bioavailability. So we are talking about half-life here and onset, because the onset can be, when onset is basically usually we do onset from the time that we consume the drug, right? And then from that time, in a conventional way, the drug will just dissolve right away and disintegrate, dissolve, and then absorb. But we can just modify it to delay, for example. That's also possible. And I think you also mentioned about different kind of materials that we can use. You mentioned HPMC and other polymers, and we also talk about this lipid base, liposome and things like that. Okay, so I think maybe for the last time, is there anything that you want to add, or?
Be excited that you study drug delivery system. There are so many opportunities.
It's really nice.
So many opportunities for you to explore. Whenever you work in a pharmacy, in a hospital, in the industry, you can always take opportunity. You can always have like a big sword to fight. Okay.
Right, perfect. And I mean, it's really nice to have this discussion today with you.
Yeah,
I
also so happy to learn from you about the a lot of stuff today that I got that I barely forgot because kurang belajar. And not in the area.
I mean, the more you learn, the more you realize.
Yeah, we have to do it more often, and we also will invite you. For example, one day you as somebody that will interview Pak Adia, you will interview somebody. That's also make you another experience that you can try.
And as you have known, I mentioned before, we'll have 5, and this one is the third session of the series. And then for the other sessions, we still have 2. One also with Bu Marlin, when we talk about organ-specific targeted delivery. And she will also discuss it with other lecturer from not only Universitas Gadjah Mada. I would like to invite someone from Universitas Indonesia and someone from ITB, Institut Teknologi Bandung. So it will become more interesting because
we will learn each other.
Yes, that's right.
Things,
and of course, we will do it online. It's not possible to do it like this, but it will be really interesting. And for the other topic, we still have the transdermal delivery system with Prof. Haris, and that will be also very exciting. So stay tuned. So don't forget to ask a question if you want. I already give you the link. So you can just do this kind of preliminary study for yourself. And if there's any question, you can just ask us in the link that I've given to you, and then we will try to answer in the session, in the live session like this. Okay, again, thank you very much.
Thank you for
Bu
having
Marlin,
me.
and,
Thank you.
I'm sorry for any
No,
limitation.
everything is perfect.
Yes. And okay, so we'll just in touch again in the next session.
Yeah.
Okay.
Assalamualaikum.
Bye. Assalamualaikum.
Assalamualaikum
warahmatullahi
everyone. Thank you
wabarakatuh.
very much.